This week we're talking about how to diagnose and determine if we might have a rotator cuff injury, but first, our disclaimer. Mike Matthews, physical therapist here with the PT411. Thanks so much for joining me. If you already haven't done so, make sure you check me out on Facebook, YouTube, Instagram, TikTok, and Twitter. Also make sure to subscribe and turn on notifications. Also make sure to check out thept411.com. So the rotator cuff tear. This issue can range all the way from a complete non-issue, causing zero pain and limitations, all the way to completely debilitating. Last week we talked about how they can show up on the MRI and be completely irrelevant to our complaints. For more information on that, make sure to check out that video. Just keep that in mind while you're going through this video. Now this video, we are looking at a few ways to help determine if the shoulder pains may be coming from an injured rotator cuff. Now the rotator cuff is just a group of 4 muscles that start from the shoulder blade back here and work their way across the ball and socket joint here. Individually, they can help rotate the shoulder one way or the other. They can also assist with motions like raising the arm up. But when they work together, they actually work by pulling the ball against the socket joint and provide stability to that joint in any direction, in any motion. It really just assists with that stability. Now, when one of them is injured, we can determine which one it is most of the time and the extent of the injury by stressing that muscle out more individually. Now, there are certain positions and movements we can do to isolate these individuals' muscles to help determine this. But the first thing we need to look at is a few general movements and pain behaviors to see if it's even worth our time to do that. Now, the first thing we need to look at is our pain behavior. After about a week of pain, if we are still having a lot of pain at rest when we're not moving the arm, it is most likely not the rotator cuff. And we need to be completely honest with ourselves when we ask that question. No, I've been in the same situation. I'm injured, I have pain, I get hyper fixated on those pains, and even when we're at rest, I'm still guarded and treating it as though that I have pain when I actually don't. If it's not painful at rest, we need to look at motion while we're using the muscles and look at the motions when the muscles are relaxed. If we take the muscles out of the equation and it still bothers us the same or even quite a bit, it's not the rotator cuff. Well, we're going to look at flexion and abduction first. We move them both actively first on their own, coming up in flexion and in abduction. Then we use our broomstick here to look at them passively, going back into flexion and abduction again. Now, if that active motion is much less than that passive, that relaxed motion, then it might be the rotator cuff. If they're limited the same between the active and the passive there, we can basically roll out the muscle and tendon unit, thus the rotator cuff. Another sign that can help guide our diagnosis is when it's hurting us during the movement. If we have pain more in the middle of the movement, when the arm is more further away from us out here, increasing that lever arm, it's probably the rotator cuff. If the pain is worse up at the top of the motion when the lever arm has been shortened again, it's probably not the muscle and most likely a derangement. And if we try to raise the arm up and we get this action right here where the shoulder complex elevates but the arm stays put, we can definitely be a rotator cuff there. So if we've looked at this movement behavior here and we think that the rotator cuff is involved, it's time to look more specifically at each muscle. First, we're going to take a look at the supraspinatus. Now, there's 2 things we can do here. We're going to look at the empty cam position. Arm is out between forward and sideways here with our thumb down. We're going to resist movement here and see if it feels weak or painful. And for the second one, we're going to do the champagne test. You're going to hold your arm out to the side like we're about to toast with a champagne, and we're going to resist downward pressure here as well. Same thing if it's weak or painful. Now, if either of these is positive on its own, the accuracy is decent. If they are both positive, the accuracy goes way up on that. We can also test the infraspinatus muscle, but there really isn't a test that isolates that one. It also includes the supraspinatus. So if this test is positive with the supraspinatus test, it can mean either both or just the supraspinatus. If the supraspinatus tests are negative, but this one is positive, it's probably just the infraspinatus. We're going to do the drop arm test. We're gonna raise that arm up with assistance. We're gonna take away that and slowly lower the arm. A positive test is that arm just kind of gives out on us like this, or it looks more something like that right there. Now for the teres minor test, we're going to start with the arm out to the side like this with our elbow bent. We're going to resist upward motion here. Positive sign is pain or weakness, or just the inability to do so. It just drops down on its own. And finally, onto the subscapularis test. We have two of them here. We're going to do the lift off sign where we place our arm behind our back. We just try to lift it straight back this way. See if we're having pain or difficulty. We can compare it to the other side. And if the other side is going much further than that side, that's also a positive sign there. And now for the belly press test, we're going to start with our hand on our belly. Elbow has to be out to the side. We're going to resist pulling away from the belly. Now this is the same as a supraspinatus. If either of these is positive on its own, accuracy is decent. If they are both positive, the accuracy goes way, way up there. Now I'm going to kind of throw in a little curveball here as well. Let's say we have classic textbook presentations of rotator cuff with one of these muscles. Do we jump straight into the treatment for it? Yeah, we can, but the derangement or impingement can mask itself as a rotator cuff injury. I did a previous video on understanding and treating the derangement. So if we go through that protocol and we see an improvement rather quickly, even if it's just a little bit, it's possibly that that's the case and it's not the rotator cuff causing our injury. Muscles and tendons do take time to heal, even when we put them in the proper environment to do so. It takes weeks to months. Derangements can be mobilized and respond very quickly to movements within seconds or even a few days. So let's say that we went through that whole protocol, that derangement treatment, and there has been no change at all. Well, now it's time to get our hands dirty and treat for the rotator cuff. We'll be looking at that for next week's video, so make sure you stay tuned. Again, I'm Dr. Mike Matthews, physical therapist here with the PT411. Thanks for joining me.